Thank you for your interest in the surgical weight loss program at St. Joseph Warren Hospital. Our highly qualified professional staff looks forward to helping you through the process of weight loss surgery. This patient education video is designed to give you some general information about obesity and weight loss surgery, also called bariatric surgery. This presentation will inform you of the various surgical weight loss options, as well as review the risks, benefits, and expected outcomes of surgery to treat obesity. As obesity rates continue to increase dramatically, a real change in how we view and treat obesity is underway. Most healthcare professionals now consider obesity a disease, just like diabetes or high blood pressure. Obesity is recognized as the cause of many serious health problems. Surgery can successfully treat many patients suffering from obesity and obesity-related illnesses. Obesity can be defined two different ways. First is in relationship to an individual's ideal body weight, and second is by determining body mass index, or BMI. The standardized chart most often used to determine ideal body weight is the Metropolitan Life Insurance Company height and weight chart. Based on an individual's sex, height, and body frame, their ideal body weight can be determined. One method of calculating your level of body fat is called the body mass index, or BMI. Your BMI depends on both your weight and your height. An easy way to figure out your BMI is to use the chart shown on this slide. Take a minute to find your own BMI. Based on your BMI, there are clinical terms used to describe levels of body fat. The ideal BMI range is from 18.5 to 24.9. If your BMI is between 25 and 29.9, you are considered to be overweight. If it is between 30 and 34.9, you are obese. If it is between 35 and 39.9, you are severely obese, and if your BMI is 40 or more, you are said to have morbid obesity. The term morbid obesity is used because this degree of excess weight may considerably reduce life expectancy and is associated with an increased risk of developing health problems. Persons in the severely obese and morbidly obese categories may qualify for weight loss surgery depending on their medical history and overall health. Morbid obesity can be defined by either being 100 pounds over an ideal body weight or by having a BMI of 40 or greater. Clinically severe obesity and morbid obesity are related to numerous health problems. Over 80% of people with diabetes are overweight or obese. High blood pressure is twice as common in adults who are obese than in those who are of normal weight. About 25% of morbidly obese patients have obstructive sleep apnea. Carrying excess weight around also causes wear and tear on joints and can result in health problems like arthritis. There are numerous other health problems that are caused by or aggravated by obesity. Treatment options for severe and morbid obesity include medically supervised weight loss and weight loss surgery. Obesity treatment is usually approached in a stepwise fashion with diet modification, exercise, and the adoption of healthier lifestyle behaviors suggested as first-line treatment. Once you reach a BMI of 30 or even a BMI of 27 with significant obesity-related health problems, you can try medicines to help you lose weight. There are several approved prescription medications for long-term weight loss. Once you reach a BMI of 40 or a BMI of 35 with significant obesity-related health problems, you may qualify for surgical weight loss if you have already tried and failed more conservative therapy. Some weight loss surgeries restrict the amount of food a patient can consume by either decreasing the size of the stomach or restricting the rate that food can pass through the stomach. Other procedures alter the absorption of calories consumed so that only a portion of the calories ingested can be utilized by the body. This process is known as malabsorption. The gastric bypass combines both effects to help patients lose weight. The three most common surgeries used in the treatment of obesity include the gastric bypass, also known as the Roux-en-Y gastric bypass, the laparoscopic sleeve gastrectomy, and the adjustable gastric band. Our surgeons perform all of the surgeries we offer through small incisions using a camera to see inside the abdomen. This approach is known as a laparoscopic approach and is used because it causes less pain and wound problems and allows for faster recovery after surgery. All surgical procedures have some associated risks. Medical complications, reactions to medication or anesthesia, and even death can occur with any type of surgery. Possible breathing complications can include pneumonia and fluid collections. These fluid collections can occur in or around the lungs. Heart complications are also possible during or after surgery and can include heart attack, heart failure, abnormal heart rhythms, or even cardiac arrest. It is also possible to suffer a stroke during or after any surgical procedure. Early mobility is encouraged to prevent the formation of blood clots after surgery. Blood clots that form deep in the veins, often in the legs, can travel to the lungs and cause extreme breathing difficulty or even death. Although many of these complications are rare, there is always a possibility of medical complications during or after surgery that you should be aware of. There are other surgical risks that can occur depending on the particular procedure performed, and these will be reviewed later in the presentation. The gastric bypass is a procedure that helps patients restrict the volume or size of their meals, as well as decreasing the amount of calories absorbed from meals. Approximately 5 to 6 feet of small bowel are surgically bypassed during the procedure, which decreases the absorption of calories. Because of the bypass and altered absorption, sickness, also known as dumping syndrome, can occur if a patient eats foods that contain too much sugar or fat after surgery. The gastric bypass reduces the normal-sized stomach to a 1-ounce pouch with a small outlet for food to empty through. Creating both a small pouch and a small pouch outlet reduces the quantity of food that can be eaten at any one time comfortably. Eating too much, eating too fast, or inadequately chewing your food can obstruct or plug up the pouch and cause discomfort, excessive salivation, and even vomiting. Malabsorption or decreased absorption of food occurs due to bypassing the first portion of the small bowel called the duodenum. Eating foods high in sugar and fat can lead to sickness called dumping syndrome. Dumping syndrome can present as nausea with or without vomiting, diarrhea, fatty stools that float, gas pain, weakness, increased heart rate, and extreme fatigue. This can occur right after a meal or several hours later in some cases. Patients who eat large amounts of sugar or drink alcohol can even experience blackouts. Alcoholic beverages should be avoided after gastric bypass, as they can cause extreme drunkenness even after small amounts of alcohol are consumed. Frequent consumption of alcoholic beverages following gastric bypass can lead to liver damage. To help you visualize how small a 1-ounce pouch is, it is equivalent to reducing the normal size stomach, which is about the size of a football, down to a pouch about the size of an egg. Weight loss results following gastric bypass will vary, but most patients will be able to lose at least 50% of their excess weight. Weight loss is fairly rapid, with patients losing, on average, a third of their extra weight by 3 months after surgery, 2/3 by a year after surgery, and 3/4 by about 18 months after surgery. It is common for patients to have some weight regain after their bodies adjust to the changes caused by gastric bypass, but the majority of patients are able to keep 60 to 70% of their excess weight off long term. There are advantages and disadvantages to every surgical procedure. Advantages of the gastric bypass include helping patients achieve rapid initial weight loss with the best long-term weight loss results. The gastric bypass has been performed for over 30 years in the United States, and there is extensive data on post-surgical results. The gastric bypass also produces the best improvement in obesity-related health problems. Disadvantages include that the surgery is generally considered irreversible and non-adjustable, and it does involve cutting and stapling of both the stomach and the small intestines. Patients are required to take vitamin and mineral supplements for life to prevent nutritional deficiencies from the impaired absorption of food. Early risks associated with gastric bypass include bleeding that can occur inside the abdomen, from the liver or spleen, from the gastrointestinal tract, from the staple lines, and from incision sites. Infections can also occur. Infections can include wound infections, infections inside the abdominal cavity, abscesses, peritonitis, and infections that occur because of leaks of gastrointestinal juices from the staple lines. Leaks can cause serious infection and sometimes necessitate a return to surgery and lead to a prolonged recovery time. There are also complications that can occur later following gastric bypass. These include strictures or narrowing of the pouch outlet that can obstruct the passage of solid food through the pouch. Ulcers can occur in the pouch or intestine and occur much more frequently in those patients who smoke cigarettes and abuse tobacco. Smoking cessation is necessary prior to having weight loss surgery. Hernias can occur at the incision site and may require surgical repair. Scar tissue can cause bowel obstructions. Surgery is sometimes necessary to correct the obstructions as well. Dumping syndrome can occur, but is usually correctable by adherence to dietary guidelines. Staple line disruption can also occur. When this occurs, formation of tunnels or fistulas may be seen between the pouch and the remnant or bypassed stomach. This complication is seen most commonly in patients with recurrent ulcers and in those who smoke. Other late risks can include fluid and electrolyte abnormalities, malnutrition, and hair loss. Adhering to prescribed dietary and supplement recommendations can minimize most of these risks. It is not possible to access the bypassed portion of the stomach using an endoscope following gastric bypass. Weight regain can also occur. Although there are risks to having gastric bypass, it also provides many benefits to patients trying to achieve lasting weight loss results. It helps patients restrict meal sizes and reduces the calories patients can absorb from meals. It can also help patients adopt healthier food choices by causing sickness or dumping syndrome when sugary and fatty foods are consumed. The gastric bypass promotes more rapid weight loss with faster resolution of obesity-related medical problems. The adjustable gastric band wraps around the stomach and other supporting tissues to create a 1-ounce pouch. The band connects to an access port that is sutured or secured underneath the skin. The port is generally placed on the abdominal wall slightly above the belly button. Although it is under the skin, you can feel it by applying light pressure to the skin and fatty tissue overlying the area where the port is placed. The pouch outlet size can be reduced by filling the band balloon with sterile salt water called saline solution. It can also be loosened by removing saline from the band balloon. Tightening of the band makes food empty out of the stomach pouch more slowly, whereas loosening the band speeds up the rate of food passage through the banded area. There is no malabsorption with the band. It works solely by helping patients to restrict meal sizes. Therefore, patients who eat a lot of high-calorie foods or drink caloric beverages may not lose weight well with a band. Weight loss results with a band will vary. Weight loss occurs more slowly than with gastric bypass, and long-term weight loss averages about 35 to 45% of your excess weight by 5 years after surgery. An advantage of the gastric band is that it is a reversible procedure and the tightness of the band is adjustable. It requires no stomach or intestinal cutting and stapling, has lower incidence of early complications, and a lower mortality rate. Patients are also less likely to develop nutritional deficiencies because all of the food you eat is absorbed. Disadvantages are that it is easier to cheat on the diet since no dumping syndrome occurs. Weight loss is slower, and obesity-related health conditions resolve more slowly as well. There is also a higher risk of returning to surgery for late or device-related complications. Early risks associated with the band procedure can include bleeding, infection, and perforation or tearing of the stomach. Reactions to anesthesia and medical complications can also occur. Late risks include a variety of device-related complications, including breaks in the band or connecting tubing, port leaks, tubing leaks, band erosion, and a flipped port. Band tightening and loosening is performed by inserting a needle through the abdominal skin to access the port below. Although every attempt is made to avoid hitting the tubing during adjustments, it is always a risk. If the tubing is damaged during an adjustment, it can leak and necessitate a return to surgery for repair. Occasionally, the port sutures fail to hold the port securely on the abdominal wall and the port can flip, making adjustments difficult or impossible depending on the degree of rotation. This can also necessitate a return to surgery to replace the port component of the device. One of the most common late complications seen with the band is caused from vomiting and is called a slip. A slip occurs when the force of vomiting causes the lower portion of the stomach to slip upwardly through the band. Depending on the amount of slippage, and if the slipped portion of the stomach overhangs the band, what we refer to as a prolapse, a partial or complete obstruction can occur. The band must be deflated if a slip is suspected, and surgical intervention is often required to reduce a slip. Surgery is almost always necessary when there's any significant degree of prolapse noted. So what does a slip look like? The following drawing depicts a slip with prolapse or overhang. This slip would require surgical repair. Sometimes a slip can be diagnosed by having a patient drink a contrast medium and taking an X-ray to watch them swallow the dye. This particular film shows a patient with a slip. The surgeon can tell that this patient has a slip because the band is flat and not positioned at the appropriate angle. The large white shadow on the right side of the film is a prolapsed area of stomach causing an obstruction. The path of the swallowed dye produces a wave-like appearance. This patient will need to be returned to surgery for a repair. The final way a slip can be diagnosed is by performing an upper scope test on a patient. The large crater-like appearance is the surgeon's view looking into the prolapsed area. This patient will need return to surgery for a slip repair as well. This final slide of a slip is what a significant slip with prolapse looks like in surgery. Most slips can be surgically corrected by unbuckling and reapplying the band, but there is always some risk that the band might need to be removed to reduce the obstruction or could break or be damaged during the repositioning process. Another major late band complication is an erosion. An erosion occurs when the band erodes through the stomach and creates a hole. This may cause gastric juices to travel down the tubing to the port, and the patient may present with a port site infection. An erosion may require surgical removal of the device. Here's what an erosion looks like. Although there are associated risks with the band can be a valuable tool for patients ready to adopt a healthier lifestyle who want to lose weight. The benefits of the band include adjustability of the device and the ability to remove the band if the patient does not tolerate it. The band is also associated with a lower mortality rate than with other weight loss surgeries. The sleeve gastrectomy restricts meal size by reducing the full-size stomach to a long, slender tube. The banana-shaped tube has a diameter about the size of your thumb. The remaining part of the stomach is removed through a port or trocar in one of the small incision sites during the procedure. Weight loss results with the sleeve will vary and can range from 42 to 78% of excess weight lost in the first 1 to 2 years after surgery. Advantages of the sleeve include that there is no cutting or stapling of the intestines required. The sleeve also preserves the normal sphincter or opening that food passes through when exiting the stomach. This results in a lower incidence of ulcer formation after surgery than with the gastric bypass. Because the sleeve helps patients lose weight by restricting meal size, there is a lower incidence of nutritional deficiencies. Although because a great portion of the stomach is removed, some deficiencies may still occur following the procedure. Disadvantages include that the procedure is irreversible and non-adjustable. Stomach cutting and stapling are required, and some patients report nausea after surgery. Nausea can be controlled with medication and usually resolves within 1 to 3 months after surgery. Early risks associated with the sleeve are similar to gastric bypass and include bleeding, infection, and staple line leaks. Staple line leaks can cause significant infection and in some cases can necessitate a return to surgery and can lead to a longer recovery. Late risks can include hernias at the incision site and ulcers, although the ulcer risk is much less than after gastric bypass. Vitamin and mineral deficiencies are also possible after a sleeve gastrectomy. Bowel obstructions are not likely, but can occur after any abdominal procedure. Risks related to dietary noncompliance are possible with all surgical weight loss procedures, even with the restrictive procedures, and can include dehydration, severe constipation, electrolyte imbalances, vitamin and mineral deficiencies, malnutrition, and hair loss. The anticipated time that you will be off from work to recover is the same for all of the procedures. Most patients can drive within 1 to 2 weeks and can return to light work in about 2 weeks. Patients may require up to 6 weeks off in order to resume manual labor. Weight loss surgery is a tool, and no procedure can guarantee satisfactory weight loss. Permanent lifestyle and dietary changes are required to be successful. At the St. Joseph Warren Hospital Weight Loss Center, the team makes the difference. Our bariatric team consists of 3 experienced and caring bariatric surgeons and a certified bariatrician. This is a medical doctor who is certified in non-surgical weight loss. We also have a full-time registered nurse who is certified in bariatric nursing, 2 full-time registered and licensed dietitians who are experienced with both medical and surgical weight loss. We have staff who have had weight loss surgery and are available to answer questions or concerns you may have. We offer support groups designed to guide and support you through your weight loss journey, both before and after surgery. Making the decision to have weight loss surgery is certainly not easy, and we applaud you for taking this important first step in gaining control over your obesity. Your surgeon will review the information in this presentation with you at your consult appointment and help you decide which procedure is best suited to your individual health needs. The bariatric team looks forward to meeting you and assisting you every step of the way.